Welcome to AETCM, the Emergency Medicine channel.
Myself, Dr. Naveen Mohan, HOD of Emergency Medicine at AIMS Kochi. And he is Dr. Ebin, MD second year resident. And he is Dr. Ebin, MD first year resident.
So shall we start?
So we will discuss about anaphylaxis algorithm today based on the Resuscitation Council UK Guidelines 2021.
Shall we start? First we come to the definition of anaphylaxis. Anaphylaxis is an immediate systemic reaction that is caused by the rapid IgE-mediated immune release of potent mediators from the tissue mast cells and peripheral blood basophils. Coming to the diagnosis of anaphylaxis, as per the AETCM guidelines, we look at the history and we look at the airway, breathing, circulation. Diagnosis, we will look for the sudden onset of airway and or breathing and or circulation problems. The life-threatening problems in airway is hoarseness of voice and stridor. Coming to breathing, we will look for the increased work of breathing, wheeze, fatigue, cyanosis and a saturation of less than 94%. Coming to circulation, we will look for any signs of shock, hypotension, confusion and decreased level of consciousness. If any one of the airway, breathing or circulation is affected, usually associated with any skin changes, we will call it as anaphylaxis. And immediately we will call for help. We will call the resuscitation team or ambulance. First, we will remove the trigger if possible, such as in the case... So
basically for all these MRCM, OSCE stations and all, you get a scenario in which patient will probably like a young adult or even in pediatrics also, a young adult like 20-year-old person who was eating some food, peanuts like in the hotel, suddenly became collapsed in the hotel and he was brought here via ambulance. That will be the history. So peanut is a very common cause for allergic reaction. It will lead to anaphylaxis also. So normally the paramedics will be giving the initial treatment to the patient, and on the way the paramedics will inform you that so and so patient is here. So you will be ready with your team. You should be ready with your team. And based on the history that they have given, it looks more suggestive of a anaphylaxis. Okay, so you should be ready with the adrenaline. What is the treatment for this thing?
Adrenaline.
As per the Resuscitation Council Guidelines 2021, adrenaline is the drug of choice. So you should be ready with, based on the age. If it's an adult, you should be ready with how much dose?
0.5 ml, 500 micrograms.
500 microgram of adrenaline at a dilution of 1 mg per ml. That's 1:1000 dilution. Should be ready. Okay. So the patient arrived. As always, you always go according to step by step, A, B, C, D, E, same pattern. So on arrival itself, you can actually give the first dose if you after getting all the details from the ambulance paramedics. If you suspect anaphylaxis, okay. If it is after consumption of peanut or whatever it is, he collapsed, became edematous or whatever. And if you suspect anaphylaxis, initially itself you can give a adrenaline first dose, and then you can go ahead with the assessment of A, B, C, D, E. Okay. So where is adrenaline usually given? The IM dose?
In the anterolateral aspect.
It's given in the anterolateral aspect of the thigh. Okay. So you will be assessing the airway. In airway, you look for
any hoarseness, stridor.
Yeah. If the patient is talking also, you should assess whether there are 3 points: hoarse voice or stridor. If that is there, and you haven't given the first dose of adrenaline so far, okay, then you can give the first dose, 0.5 ml or 1:1000 adrenaline in the anterolateral aspect of the thigh. And the reassessment of the effect of adrenaline will be after 5 minutes. Okay. So once you have given that, you can place NRBM with high flow oxygen. Okay. If the respiratory rate is adequate, if it is between normal respiratory rate, you can keep an RBM with high flow O2 and move towards the B. Because airway is already patent, no secretions, nothing is there. But there is impending chance of airway compromise. For that, you have already given adrenaline first dose, right? Okay, you don't need an IV line because it's IM dose, IM. Then once that is taken care of, you can move to B, wherein you grossly look at the RR and SpO2, and then you do, as always, you do inspect for the, expose the chest, connect all monitors, inspect for the neck, see for the trachea, neck veins dilated or not, then inspection, palpation, percussion, auscultation of the chest. And if suppose there is wheeze at that point of time, will you do anything? No. As per the guideline, you have given the first dose of adrenaline. Okay. After 5 minutes only, you are supposed to reassess. Got it. No? Suppose you reached B, and it is by this time it's 5 minutes. This is already over. Okay. If the last dose of adrenaline was given 5 minutes before, maybe in the ambulance also these paramedics would have given. If the last dose of adrenaline was 5 minutes before, then you can repeat a dose of adrenaline. Okay. Then it becomes 2 doses of adrenaline. So there is intervention. Once you do a complete assessment of B, and in B, what all things you look for, whether there is an increased work of breathing, whether there is wheeze, whether there is fatigue, whether there is cyanosis, or if the saturation is less than 94%. Okay. Then you administer the second dose. Only if the drug was given
5 minutes back.
5 minutes back. Okay. Then you move to circulation. Okay. There you will be what all things? You will be looking for the heart rate.
Signs of any shock, hypotension.
Yeah, heart rate, blood pressure, capillary refill time. And then you'll be connecting all the monitors and all. Then you'll be auscultating the chest for heart sounds, for muffled heart sounds, all these things. As always, just like any ALS or APLS resuscitation station. And then you place a large bore IV cannula, extract blood for hematology, biochemistry, blood culture, blood gases. And also, one more thing, in allergy specifically,
the mast cell tryptase
levels should be drawn at that point of time. Okay, that is important because we want to prove that this is anaphylaxis, truly anaphylaxis. Okay, that is based on the mast cell tryptase levels. Got it, no? Okay, then if suppose there is a hypotension, or if suppose there is, what all things you will be looking in circulation basically for? If there is a low blood pressure, or if there are any signs of shock, or if there are any signs of confusion or reduced consciousness, because these are all indicates perfusion, right? Okay, whether you look for all these points in circulation. Okay, and if will you give adrenaline at this point?
If 5 minutes is passed, only then we will.
Yeah, if 5 minutes have passed, then normally it will go into a refractory anaphylaxis, and you have given 2 doses of adrenaline. Then the scenario becomes a refractory anaphylaxis. So normally, but the thing is, generally, if you in the ED and all, ABC as ABCD, all these things, assessment will be over within 2 to 3 minutes. It won't take this much of a time for the primary survey. All these things are happening in the primary survey. Okay, normally after you give the first dose of adrenaline, once you go back and reassess your ABCD, then only you'll be giving the second dose of adrenaline, because everything will be over within 2 to 3 minutes. So if you are well experienced in your emergency management and all, it will be over in 2 to 3 minutes. Okay, continue.
Then if you find any airway
and one more
breathing,
thing, for this, we told IM injection is given the anterolateral aspect of thigh. What gauge of the needle is generally used?
23 gauge.
Yeah, 25 mm 23 gauge blue needle is generally used. This usually comes as a question, especially for an SBA exams, Markham SBA. They'll be giving all sorts of this thing, but this is their answer. Okay. You should note that nowhere in this algorithm they have mentioned about hydrocortisone, Rantac, Avil. Nothing has been mentioned. So according to the latest resuscitation guidelines 2021, Avil, Hydrocort or Rantac has got no role. Only adrenaline. Only adrenaline. Okay.
If airway, breathing or circulation is compromised, then we will give IM adrenaline.
In what, and the other thing, immediately on arrival, in what position will you place the patient? What is the
supine position and not on standing position?
Yeah, only at standing position is not
advised.
Either the patient can lie down flat with legs elevated, because chances of hypotension is there, or else you can make the patient sit legs, like just like I'm sitting, you can make him sit. Don't make him stand. That is the guideline. Okay. And if the patient is pregnant, you can place the
flat
on the left side also.
If airway, breathing or circulation is compromised, then we'll give IM adrenaline.
Yeah, basically, if there is a sudden onset of any issue in A, B, or C, okay, in a suspected case of anaphylaxis, okay, then you term it as anaphylaxis, and usually it will be associated with some skin changes, usually some itchy rash or something, but it's not merely an itchy rash is not sufficient to label it as anaphylaxis. Some issue should be there in the A, or in the B, or in the C. A issues are either hoarse voice or stridor. B issues are increased work of breathing, B's saturation less than 94, fatigue or cyanosis. And C, the issues are low BP, signs of shock, confusion, and reduced consciousness level. Basically hypoperfusion things. Then only it is called an anaphylaxis. Otherwise, if it's a merely rash and all, you may call it urticaria. Okay, got it, no?
Then we will administer the first dose of adrenaline and we will assess the patient after 5 minutes. In the parallel, we can also advise IV fluid bolus if needed.
That is if the BP, if you gave adrenaline, normally you start on IV line is already in situ. There you can give IV fluid bolus for C if there is hypotension or shock. Any of the C issues are there, means you can give IV fluids. Normally, what will you give? Crystalloids. NS or RL or whatever you can give. And what is the dose that is advised?
Adults 500 to 1000 ml and in children 10 ml per kg.
Yeah, 500 to 1000 ml bolus in adults, and in children
10 ml per kg.
10 ml per kg. As per the wet flag and all, you can give. Yeah, that is the first dose of this thing. First bolus. You can actually increase. You can give further boluses. Further boluses can be given up to even 3 to 5 liters. Okay. So now you have dealt with the circulation, right? Okay. No.
If the patient is still not improving after 2 doses of IM adrenaline, then we will label it as a refractory anaphylaxis.
Yeah.
The doses of adrenaline IM is 1 mg per ml, 1:1000 dilution. For adults and children more than 12 years, 500 microgram IM, that is 0.5 ml, and children 6 to 12 years, 300 microgram IM, that is 0.3 ml, and children 6 months to 6 years, 150 microgram, that is 0.15 ml, and child less than 6 months, 100 to 150 microgram IM, that is 0.1 to 0.15 ml is administered.
You should remember the dosages exactly. Okay, because the age group that can also come as a question. Depending on the age, suppose it's 13 years, shouldn't say 300 micrograms, it's 500 microgram. Okay, more than 12 years is considered like equivalent to adults. And if it is between 6 months to 6 years, suppose it is a 3-year-old child, you should give 150. Okay, and less than 6 months, it's between 100 to 150 micrograms IM. You can just remember like less than 6 months also 150. That is easier to remember. Okay, and also 1:1000
dilution.
dilution. It is not 1:10,000. Okay. And for this to enable the patient to be having anaphylaxis, there should be a previous sensitization is also required. Then only you can call it as anaphylaxis. If there is no sensitization, it will be called as the anaphylactoid reaction, because that is not IgE mediated. Okay, that is different. Okay.
If the patient does not improve with 2 doses of IM adrenaline, then we will label it as refractory anaphylaxis. Coming to the management of refractory anaphylaxis, we will establish the peripheral IV or IO access. Then
it's written no improvement in respiratory or cardiovascular symptoms despite 2 doses of intramuscular adrenaline. Respiratory or cardiovascular symptoms. That is the thing. All right.
We will give rapid IV fluid boluses that we can give up to 3 to 5 liters in adults. Ideally, crystalloids. By the meantime,
you can also with Hartmann's solution also you can use. Even plasmalite also you can use. Okay.
By the meantime, we will start the patient on adrenaline infusion. At 1 mg in 100 ml NS infusion pump we will start, and we will start the infusion at the rate of 0.5 to 1 ml per kg per hour and titrate according to the clinical responses.
That is also one question. Adrenaline infusion will be started at what dose? This thing will be 0.5 ml in 100 ml of normal saline, not by infusion pump. The other one will be 1 mg in 1000 ml. They'll try to confuse you with several options. The option is, what is it? 1 mg in 100 ml NS via infusion pump. Okay. So that is basically, if it is a refractory, give further boluses, fluid boluses, and start on adrenaline infusion. Okay. And if there is a delay in starting an adrenaline infusion, you can go ahead and give the third dose of adrenaline IM. Okay.
In refractory anaphylaxis, if still the patient has airway compromise like partial upper airway obstruction.
After C, then you will be going to D. A, B, C, D. D is a GRBS, GCS, pupils, lateralizing signs as always. You do it, and then exposure. Look for temperature, any rash, because allergy can be associated with rash, angioedema, and all these things can be there. So you'll have to assess that temperature and prevent hypothermia. Then afterwards, you again reassess, go to A. There you'll again see the patient has got any stridor, any horse and surprise, any impending airway compromise. Okay, so if there is a stridor, if you feel there is a evidence of partial upper airway obstruction in the form of stridor, suppose on reassessment of ABCD, if in A, if still there is stridor A, what will you do?
We can give adrenaline nebulization.
There you give adrenaline nebulization. There only you will give adrenaline nebulization. Got it, no? Okay. What if there is a complete total upper airway? His tongue is completely swollen. Okay, the airway is completely, you can't place a...
Then we will need a expert consultation, or we have to follow the difficult airway algorithm.
Yeah. If there is a complete airway obstruction, follow as per the resuscitation guidelines. You call the anesthesia and follow the difficult airway algorithm, which is called the DAS algorithm, the Difficult Airway Society algorithm. You can just go through, and probably you'll have to, the tongue is that swollen, you may have to go ahead with a surgical cricothyroidotomy. And surgical cricothyroidotomy will fall in the plan D of the DAS algorithm. Plan D. You can just go through that. Okay, because that is the last resort. You have nothing more left. So before even arrival of the patient, you should be ready with all your airway equipments, including surgical cricothyroidectomy. That is a mandatory. Okay. Okay. So once you have B and there is a partial airway obstruction, you gave adrenaline nebulization. Okay. Then that is your intervention. Now you're moving to B.
If the oxygenation in breathing, the oxygenation is more important than the intubation. If apneic, we will go ahead with the bag and mask ventilation, and we will consider tracheal intubation.
Yeah, if the patient is apneic, means that is breathing is not, the respiratory rate is not sufficient. That means that is insufficient to wash out the carbon dioxide. So you'll have to give support. You'll have to give a bag valve mask ventilation. Okay. If that is not also not improving, you may have to go ahead and do intubation. Okay.
If there is severe or persistent bronchospasm, then we will nebulize with salbutamol and ipratropium with oxygen. And we will consider IV boluses of infusions of salbutamol or aminophylline.
Yeah. Basically in B, when you auscultate, similarly, just like in the second round, when you encounter B, if there happens to be a wheeze, okay, then what will you do?
Nebulize with salbutamol.
The thing is, adrenaline infusion is already on flow. So you don't need to repeat adrenaline doses there because it's already on flow. Now the next option is salbutamol or ipratropium nebulization. Okay, and if possible, you can, if needed, you can give an IV bolus or infusion of salbutamol or aminophylline. And then inhalational anesthesia is also recommended.
Then we come to C. If the circulation is compromised, then we can give further fluid boluses and titrate according to the response.
Yeah. Up till 5 liters can be given in adults. And if still, in spite of adrenaline infusion and in spite of giving 5 liters of fluid, it's not improving, you can start on other supports such as noradrenaline, then vasopressin, and then metaraminol. Okay. And suppose the patient, if they say that the patient is already a known hypertensive, already on some beta blockers and all, then you should always think about refractory anaphylaxis. Okay, if in the scenario, if they say patient is already on beta blocker and they have happened to have some peanuts or prawns or whatever, and had an anaphylaxis, always think about refractory anaphylaxis, and in such cases, administer glucagon. Okay. So that is one MCQ question that they can ask. Beta blocker, refractory, what next? All right. Then afterwards, if nothing,
we can plan the patient for
extracorporeal life support. If nothing is working. Okay. By this time, the other team would have, the critical care team would have arrived on scene, and you will be handovering. Most of the time, patient will get improved with all these interventions, and you can hand over the patient to the critical care team. All right. That is how it goes. And suppose the patient improves, will you discharge the patient now? Suppose with 1 dose adrenaline, patient had anaphylaxis, with 1 dose of adrenaline, 0.5 ml, patient improved. So will you discharge?
Fast track discharge can be considered within 2 hours after observation for 2 hours if the patient improves with first dose of adrenaline.
That means after resolution of all the symptoms of anaphylaxis, you should observe for 2 hours and then you can discharge. Okay. And that is if the patient has responded to 1 dose of adrenaline. That is the criteria. Okay, so what is the next criteria? If suppose the patient has responded only to 2 doses of adrenaline. Okay, after 2 doses, patient became symptomatically better, anaphylaxis improved, ABC, everything is okay. then what will you do?
We'll observe the patient for 6 hours after complete resolution of the symptoms.
Yeah, once patient is completely symptoms have completely resolved, you observe for 6 hours, and then you discharge. Okay. Then, if they require 3 doses of adrenaline, or we started on that, it is a refractory anaphylaxis. We started on adrenaline infusion. Then will you discharge? And now the patient has improved. Now then will you discharge?
A minimum 12 hours observation is needed after complete resolution.
Yeah. Minimum 12 hours. Okay. So what they say generally is patient can be kept in the emergency department itself. Even they don't say it's transferring it to critical care team. Okay. But here and all, we generally transfer if it is too much of a refractory and all, we'll admit in ICU, right? Okay. But there, and the thing is, in UK and all, you can observe the patient for 12 hours and then discharge. Why so much of observation is required?
Late phase reaction, biphasic reaction.
Yeah, biphasic reaction can happen. Late phases and all, patient can again develop similar symptoms. Okay. So what are the risk factors for biphasic reactions? When do you suspect that the patient may have a biphasic reaction?
The patient need more than 1 dose of adrenaline to settle. And any previous history of any biphasic reactions?
Yeah, previous history of biphasic reactions. If the initial presentation is very severe, and if there is a delay in adrenaline administration. Okay, so as early as possible, you should administer adrenaline IM. It's better to even before you start your A assessment. I think it's better to on arrival itself. Okay, because that can delay further complications. And if you're planning to discharge the case, will you give something to him? Like if there happens to be a recurrence, you should give some auto injector and all.
EpiPens can be given.
Yeah, there is something called EpiPen. They have it like they can just inject. Okay, and EpiPen and Jext and then Emeroid. Three items are there. Depending on the dose, EpiPen and Jext is available in 0.3 ml and 0.15 ml, and Emeroid is available in 0.5, 0.3 ml, 0.15 ml. And these are all for fast track discharges. Okay. And one more word about this thing. You have already taken the first dose of mast cell tryptase. Any idea about what is the relevance?
To prove the patient is in anaphylaxis, we need to send
So basically, you have to take 3 samples. First sample of mast cell tryptase. You basically take it in circulation once you place your IV line. You take for the blood and cells and for mast cell tryptase as soon as possible after resuscitation is commenced. And the second dose should at around 1 to 2 hours after onset of the symptoms, and the third dose at 24 hours after taking the first sample. So 0 hours, 2 hours, 24 hours. The thing is, the mast cell tryptase usually peak at around 1 to 2 hours, and then the concentrations are back to normal within around like 6 to 8 hours. So if in the second value happens to be a peaking, you can be quite sure that it is a anaphylaxis. Okay, otherwise it may not be anaphylaxis. Got it? So that is the relevance. So basically, tryptase is the major protein part of mast cells, and the mast cell tryptase test is to confirm the diagnosis of anaphylaxis in cases where the diagnosis is uncertain.